Keys for the successful treatment of articular cartilage injuries in the knee. What's going on, guys? My name is Dan Pope. We have Kevin Coughlin. We are physical therapists at Champion PT and Performance. Like always, we're going in the literature. We're doing deep dives. We're picking up all the good information, and then we're combining our clinical expertise, hopefully teach you a little bit. What's going on, Kevin?
Not much, Dan. This was another fun one to dive into. And like we just said before we started filming, going through it, it's beefy. So there's a lot of material here that we'll go over and I think could be pretty helpful for people.
Let's dive it in.
All right. So just an overview on this lecture here, kind of what are we going to be going over? First of all, can we manage these conservatively, these cartilage defects in the knee, and special considerations for youth athletes? What are the indications for surgery? When are we going to decide to send someone to a surgeon, and when might they decide to do surgery? What is the surgical prognosis? So how do these people do long-term, short-term and long-term, and what are return to sport rates like? Some special considerations just for different populations. And then just going over kind of a sample rehabilitation program. I know we've touched on this in a few different types of knee injury podcasts, so I won't belabor every single step of the rehab process, but I think some overarching principles to consider will just be helpful.
I can't wait.
Let's go. All right, so just kicking it off here a little bit about can we do surgery and or can we rehab conservatively? Kind of thinking about that. I think these were two pretty good papers that I came across. The top one there, articular cartilage repair of the knee in children and adolescents. I think that's pretty relevant to us at Champion, where we just see a lot of youth athletes. So I thought that was pretty good. And then that was in 2018. And then the second paper here from 2022. Rehabilitation, restrictions, and return to sport after cartilage procedures. So looking a little bit about the rehab and the return to sport in that one. So these were two pretty good articles here that will be highlighted in the next few slides.
So it looks like solid papers. I'm excited.
Pretty good. So getting into non-operative management. So cartilage lesions in isolation, they don't prevent athletes from returning to sport. It's not like if you have a cartilage lesion that no matter what, you need surgery. I know in our previous episode about this, we talked about the different grading systems and when a certain amount of cartilage damage lends to surgery. So we will talk about that. But just a lesion in isolation, and I think that's important because there's a difference between widespread degeneration, which is what we start to think about with osteoarthritis, and these localized lesions. These are different, and these are usually from a traumatic type injury that we see in younger athletes. So just keep that in mind. In professional and recreational athletes evaluated by MRI, the rate of asymptomatic lesions ranges from 41 to 47%. So in your higher level athletes, professionals, and recreational athletes, a fair amount of these, almost half, have asymptomatic lesions in their knee. So that's pretty crazy. A quote from this paper here: there is no current guideline on when to treat asymptomatic lesions, and research offers mixed outcomes when they are present. So this is obviously the big kind of meta question: is you have someone with a lesion, a cartilage lesion, and it's asymptomatic. How much do you care about that? How careful should they be? And I think I have a lot of patients. You hear this very, very often, is maybe someone has a little bit of cartilage damage and now they're told by their surgeon that they should stop running because of the impact, or they're cautious with different activities because they don't want to make their cartilage worse. And this is hard. We don't have good guidelines on what these folks should do. We don't know how aggressively to treat them, specifically with impact activities. So I will talk about kind of the way I'll think about it and from what some of the experts in this field kind of were saying, but we don't have great guidance. It's not like if you have an asymptomatic lesion, avoid X, Y, and Z and do A, B, and C. We really don't know. So it's just something to proceed with your clinical expertise, I guess. And we'll talk about how I think about doing that. Wagner et al., they cite a study comparing isolated ACL injuries to ACL injuries with asymptomatic cartilage lesions. And the average size here was 2.1 centimeters squared. So for most grading systems, that's considered small. It's right on the cusp there of maybe a small to moderate lesion. And these were 42 patients And at 10 years, 42 patients followed up at 10 years, and 36 patients followed up at 15 years. So a decent number with a more long-term outcome. And again, that's ACL versus ACL with asymptomatic cartilage lesions that weren't done. They didn't do anything to it surgically. And basically, they found no difference between groups with the IKD committee criteria, the Lysholm criteria, and the Tegner activity scale. So in this cohort, there wasn't much of a difference long term if you had an asymptomatic cartilage lesion or an ACL injury by itself. So I think that was interesting and hopefully makes us feel a little bit better that if you do have some asymptomatic cartilage damage, it doesn't always mean things are going to get way worse. I think it very much depends, but I thought that was pretty cool.
Yeah, that's pretty cool. I'm kind of curious if you have a symptomatic cartilage with the ACL, if that changes at all. Are you going over that at all, Kevin? Or
I am, yeah, and I do think it changes quite a bit. So we'll
oh
talk about
boy,
that. Yep.
all right, we'll get into it. Let's do that. Pardon the interruption, but I've got something that's going to blow your mind to smithereens. It's an evidence-based cheat sheet on articular cartilage injuries. Let's face it, staying up to date on all these topics, really tough as a physical therapist. Only psychopaths like me try to keep on top. And my promise to you is I'm going to catch you up to date on articular cartilage injuries under 10 minutes. We go over all the good stuff and none of the fluffy stuff. Background, incidence, prevalence, the grading of injuries, the association between ligament and meniscus damage and cartilage injuries, clinical presentation and diagnosis, which cartilage surgeries are going to be most prominent, like microfracture, OATs, and ACI. I'll let you know why you do one over the other. So click on the link in the description. This cheat sheet is 100% free. Like I said, my promise to you, catch you up to date under 10 minutes. Now, back to your video.
So continuing with non-op management, these were just a little bit more information from those studies. So lesions are associated with greater annual loss in cartilage volume. And this is in healthy middle-aged adults, which may correlate with future OA formation. So just a note about kind of that study we just talked about. If that was in younger folks at 10 to 15 year follow-up, maybe if you kept following them as they got older and older, they would go on to develop osteoarthritis. We're just not sure, but it does seem like these asymptomatic lesions over the course of time might lead to loss of cartilage volume. So something to consider. The study found that the loss of tibial cartilage of 2.5% annually in those with known defects compared to 1.3% in those without, independent of other known risk factors. I think the important thing here to consider, though, is that the loss of cartilage wasn't the widespread loss of cartilage wasn't always symptomatic. So it's just an interesting finding that if you do have some of these cartilage defects, you might be losing cartilage volume at a faster rate, but how much does it matter clinically? I think we still don't know. So their kind of summary here is further long-term studies may elucidate whether these lesions need to be addressed when first encountered in a patient if asymptomatic. But the current sentiment is to observe these lesions offering no real intervention. So good luck if you have an asymptomatic lesion.
Yeah, it kind of seems a little bit like the rotator cuff, right? I was just hanging out with Dr. Rocket, who's a shoulder surgeon over the weekend, and he says if you have asymptomatic large tear, maybe it's worthwhile, right? So larger, massive, and younger person, but he doesn't do that. You know what I mean? And people don't come to him unless their shoulder hurts, right? But that's always the thought. It's like, if we can repair this early on, is that going to reduce osteoarthritis? Should we go for it? Should we not? Maybe it's not symptomatic. You shouldn't mess with it. But the other piece is like, who knows? Maybe if you did repair it, it would create more, less osteoarthritis over the course of time. It's just, we don't know that, I'm assuming.
All right. And then just some further findings here for non-operative management. This is a quote from another paper here, number 2 in the references. So we propose treating children and adolescents suffering from knee joint cartilage defects, fresh flake trauma excluded, for at least 3 months conservatively before kind of thinking about surgery. So that was one of their positions here. So I think that's good to keep in mind. You don't necessarily do 2 or 3 weeks of PT and say, things aren't getting a whole lot better. Maybe you can give it a little more time and see if they do a little better before referring back for surgery. And I guess this would be in a symptomatic type case, and that's going to depend on the size of the lesion. But I would say safe to say if they've already seen a surgeon and they've had imaging, and the surgeon says, all right, let's keep an eye on this, go try physical therapy, we'll see how you do. You want to make sure the patient knows we got to give this at least probably 12 weeks to see how you do, and if things are calming down or not. And if they're not, maybe then we'll send you back to the surgeon. Another quote here from the paper is, there is, to the best of our knowledge, no published evidence on the outcomes of non-operative chondral knee joint treatment in children and adolescents. So we just need more research in this field, is kind of the theme with that. More on this on the next slide, but the authors recommend, when asymptomatic, probably best to avoid surgery. If they're not having a problem at this point, we don't have enough good evidence to say, you're asymptomatic, let's go ahead and do the surgery anyway for the long-term health of your knee. That may change, but as of now, that's kind of the recommendation. But surgery is indicated for grade 3 or grade 4 lesions. And this is where it gets a little gray, and I think it depends on the surgeon's preference. If you are asymptomatic with a grade 4 lesion, I think that's unlikely, but you probably have symptoms at that point. But they may go ahead and want to do surgery anyway, because these can progress quite a bit. So there's a little bit of a gray area there. But I would think generally asymptomatic, let's try some physical therapy. If it's a very high grade lesion, grade 3 or definitely grade 4, you probably would have symptoms at that point. But if you don't, that's a little gray area and may depend on the family's decision, the PT, and the surgeon's recommendation for that.
So essentially, if you have a patient that comes in and they've got maybe a little bit of intra-articular swelling, right? And it kind of behaves a little bit like a meniscus injury, kind of behaves a little bit like a cartilage injury. You send them to the doctor. Doc says, grade 2 cartilage injury, send them back to you. Essentially, at that point, you're treating that conservatively. Is that kind of what I'm hearing?
Yeah, I think that's fair. And then basing your long-term progressions on symptoms and swelling and worsening pain, like we talked about, I think in a previous episode on this, is that progressive, unrelenting swelling may be what's doing more damage to the cartilage over time. So if you're just progressing this like a knucklehead and the person keeps getting flared up, you may be making things a little worse. So conservative care works, but we have to be cautious of what we're doing with the patient from an exercise standpoint. And nothing would inherently be off limits if they're progressing well and they're not showing worsening signs of swelling and pain, I would say.
Yeah, I do think that maybe this is a little bit different than the way we would treat, let's say, a tendon issue, right? It's just my gut. I don't have like good research to support this at all. But when someone has tendon-based pain, usually we're, to steal a word from Chris Johnson, a little bit more cavalier, right? We kind of push them as much as they can handle for the most part. We know we're not causing more damage. From like a joint pathology perspective, usually I'm just going a little bit more slowly and being more cautious, and then really monitoring for symptoms over the course of time. And I'd say I'm really not as cavalier. I don't like to push folks with like intra-articular pathology as much. That is potentially a good reason. If you overdo it, right? We don't have that quiet knee anymore. Maybe that's causing more cartilage injury. I'm not really sure. Any thoughts on that, Kevin?
Yeah, I think that's really good advice, and I think that's usually what I'll try to do myself as well. And maybe it's because the tendinopathies, we're just not seeing that same kind of active inflammatory process that can be so damaging. Uh, and maybe it's just that even if there is some inflammation, that tendons don't respond as negatively to that as cartilage does. So I think it's fair to say these are different anatomical structures that may respond differently to pain and swelling. And I usually say the same thing, like, let's tendon pain, let's work up to maybe a 3 or 4 out of 10, make sure symptoms are stable and return to baseline usually within 24 hours or so. For intra-articular things, I think I'm a little bit more like you, maybe a 0 to 1 or 2 at most, but we're not getting worsening loss of motion or swelling and stuff like that. Kind of making sure those are staying negligible, not increasing at all, is what I really prefer.
Yeah, good stuff.
Yeah. Okay, so this table here, just made a note. So But this table is from one of the studies I thought was pretty good. So this was a kind of position paper, or like a current concepts paper, with different medical doctors who do surgery for cartilage defects. I thought this was good. So treatment principles for chondral and osteochondral defect repair in the knee joint among specifically children and adolescents. So I won't read every single point here, but the general idea is that we're generally treating this with conservative therapy first for the treatment of symptomatic cartilage defects. Even if it's symptomatic, we might be able to try these first if it's a lower grade lesion, like a grade 1 or grade 2. And so in that case, you can go ahead and try conservative care potentially and see how people respond. But in the case of a grade 3 or 4, some type of surgical cartilage repair is probably recommended, because there might be enough damage that pushing through with therapy just may not lead to the outcomes you want. And I think the rest of this slide could be worth looking through if you have access to the YouTube video, or diving in and looking at the paper, because after those broad recommendations on who should get surgery, these surgeons talk a little bit more about what type of surgery should be done based on certain findings on the imaging. So I won't go over all that, but I think it could be worth checking out and just looking at a little more if you're interested in that.
And just briefly looking at it, I think you actually covered a lot of this stuff in your last podcast as well.
Mm,
So I'll leave that link in the show notes if you guys haven't checked it out. But basically, which surgeries are going to be indicated if they do have a grade 3 or 4. So
sweet. Okay, so shifting gears a little bit to another paper that I thought was pretty good here from the Journal of Knee Surgery 2020, non-surgical management of cartilage defects of the knee: who, when, why, and how. So we'll get into this paper a little bit. So why try conservative management? What's the big deal if surgery outcomes are pretty good? So obviously, a lot of people want to avoid surgery, and cartilage defects can progress in the form of focal lesions or diffuse articular cartilage loss. So I guess the idea is that for some people, if you can buy time with conservative rehab, maybe they have a little bit of widespread cartilage loss plus a local defect. If you go ahead and you get a knee replacement at a younger age, it may not have the lifespan you want out of it. So if you can do some conservative treatment and prevent going in and doing a cartilage defect repair now, and you still have some chance of pretty gnarly arthritis, you don't want to have those two surgeries in a short period of time. So it may be worth rehabbing the cartilage defect, trying to maintain the integrity of the knee joint, and then delay your total knee replacement for further down the road, where you have a longer lifespan of the knee replacement and you don't necessarily require a revision surgery. And the paper here just mentions that 35% of patients who receive a total knee replacement in their early 50s require a revision surgery during their lifetime. So, that's something to consider, is that if someone's in their 40s or 50s, you may want to try to rehab this conservatively, even if they are having some symptoms, because if the alternative is a knee replacement, we don't want to have these people need to get a revision for that down the road. So just something to keep in mind on why conservative management might be helpful, and how you could explain to your patient what the goal of this rehab is, so we can delay that knee replacement for further down the road when they're older.
not to sidetrack you at all, Kevin, but someone getting a total knee replacement in their 50s, 35% of those folks are going to need a revision. What's that? 65% of folks don't? That's kind of crazy. It's the majority of folks in their 50s are not getting a knee replacement. Not to sidetrack you too much, but just to come back on maybe how long these knee replacements last, they're maybe doing a little better than sometimes people know. That was one of my thoughts there based on what you said.
Yeah, and I think it's one of those things, right? They're just getting better with time. It's like the technology is just more and more advanced, so it's pretty cool. So yeah, you could look at that half glass full or half empty type thing. So further non-op rehab strategies. So what are we going to do? We have someone in for non-op rehab. What do we have at our disposal? Obviously, as physical therapists, we're going to be looking at exercise. So there's a little crossover here with these studies, just talking about osteoarthritis versus cartilage defects. They don't always isolate one versus the other. They're kind of grouping them together. But what do we know broadly is good for cartilage health? So obviously exercise. A review of 24 studies concluded that structured physical activity interventions have mainly positive outcomes on cartilage structure. So this can be the gamut of things like walking or running. You can do a little walking and running. I think that's okay. Aerobic activities, strength training can be really good for cartilage health. Even flexibility training seems to be positive for cartilage health. So the healthier you are from an exercise standpoint, it's going to be good for your cartilage. And I think it just comes with the caveat that whatever that person's doing, you're just educating them on monitoring things like pain and swelling. And if those are getting worse, you just modify the exercise. And this is where we can really shine as PTs. I think we can do a really good job finding the right exercise for the right person. There's always something that someone can do. You just have to figure out what their best tool is from an exercise standpoint at the time you're seeing them. And then other things that I think are in our scope, we should be advocating for these things. And I think there's a good way to do it. But if we have to refer to somebody else with better expertise in this, we should. So we know that weight loss, nutritional guidance, just promoting a healthy lifestyle can be really helpful for cartilage health. Multiple epidemiological studies have suggested a relationship between obesity and the presence of cartilage defects from a mechanical and biological standpoint. So we can't ignore the fact that obesity does have some impact on cartilage health, and whether that's all mechanical or it's a mix of mechanical and biological kind of metabolic health has some impact on cartilage. And we want to, point our patients in the right direction to try to get better overall health and body weight. There was a trial, the ADAPT trial, which is arthritis diet activity promotion trial, showed that for every kilogram of weight lost, knee joint loading forces decreased by about 4 times that amount. So pretty significant if we're trying to reduce load into the knee. That would be one way to go about it. This study also showed that following weight loss, individuals had improved time in a 6-minute walk distance, stair climb time, and self-reported WOMAC with less pain during the tests as well. Obesity is also associated with altered lipid metabolism and low-grade systemic inflammation. And we know that these things can contribute to worsening cartilage health from a biochemical standpoint. So again, this is very important, and I think something we could address with these folks. And then finally, there wasn't a ton of specifics on this, but this study did mention as a potential non-op treatment is orthobiologics. And sometimes they do things like I'll always say this wrong, but like hyaluronic acid injections, perhaps PRP injections. I think they need more definitive research on that. But if you do have a good orthobiologics doc in your network, it could be worth referring this patient to them, and maybe it helps get them over the hump from a pain standpoint. And then we can address all these other things as well, I think, which would be good.
If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free mini course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks, because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you, and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the fitness pain-free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now. Yeah, cool. Like it, Kevin. A few thoughts I thought here. One, I thought it was interesting that weight loss improves function, right? So one of the biggest things that we do as physical therapists, we're trying to improve function. And it's just kind of, I mean, it's no brainer, it makes sense, but just simply if we can get our patients to lose weight, it's probably going to make them more functional, right? And I'm curious, is it the weight loss that made them more functional? It was the exercise maybe they did to lose weight, right? They created this. Either way, it's just very powerful from an osteoarthritis standpoint, cartilage standpoint to try to lose some weight, right? The other one, I thought this was pretty interesting. And I kind of learned about this when I was doing some literature review stuff for knee osteoarthritis. And you mentioned it there, but obviously if you have more weight in your body, it's more mechanical strain through the knee joint. But the other piece is that obesity, just having extra adiposity, is pro-inflammatory, just as you noted, right? And you have something called cartilage homeostasis in our joints. So essentially your cartilage is kind of breaking down and building up over the course of time. And as we live our lives, usually this is a net loss. Hopefully you don't lose it so fast so you have a lot of symptoms over the course of time. But if you have extra adiposity, you have a little bit more breakdown of cartilage and a little less buildup. So one of the best possible things you can do to keep your knee joint healthy and any joint in your body is just to maintain a healthy body weight. So I try to mention that with my patients as much as possible. It's always tough when you're trying to bring up weight with patients, and we're not always the experts with this. If you are pretty good, you can give them a few pieces of information, help them out. Awesome. Otherwise, I just think that was really smart. Refer out. Know some good nutritionists you can refer out to help those folks out because it's very, very challenging to lose weight in general, and we're not always the experts to do that.
Yeah, I'll just say I think that's awesome because a lot of times if you just think about weight loss for in terms of knee arthritis from a mechanical standpoint, then you also tend to think that certain exercise is bad because it's more mechanical stress. So it's always comes back to load, and that's not necessarily the case. And you can explain that to your patient, like you had said. A lot of times it is an inflammatory type thing that is like a biochemical thing that's contributing to the loss of arthritis, and that exercise helps so much with that. It creates a healthier metabolic system. So, it's not always mechanical, because if they think that, then they think certain types of exercises are too mechanical and it's going to damage their knee. So it's important that they understand that no, exercise is good because it's helping you metabolically and it's helping just your whole body. And it's not a stress ratio of this much running is this much stress on your knee, so you can't run. If the pros outweigh the cons, I think, in terms of the metabolic health you get from certain activities. So yeah.
Yeah, it's kind of like that old saying of like you only get so many heartbeats in your life. So when you
Yeah.
exercise, you're wasting a lot really quickly.
Yep.
That's not true. Like you only have so much loading of your knee. It's a little more complicated than that, right?
Yeah. I won't make it political, but I think our current president said something like that about about exercise. Just
Yeah,
only has so many heartbeats. You can't waste them on exercise. But
it's not true. Just so you know. Yeah, you heard it first.
yeah. All right. So surgical considerations and types of surgery. So we talked about this in our previous episode, but consider surgery if You failed conservative treatment. Obviously, that's going to be a big one. You're just not getting better. There's worsening pain and swelling with conservative treatment. We might want to do surgery. That ICRS grading system, if you have a grade 3 or 4, perhaps you're a better surgical candidate, and the surgeon I think that you're working with could help you figure that out. In conjunction with the first thing, you're symptomatic without a resolution of symptoms, things just aren't getting better. And then we didn't touch on this, but we talked about this a lot in the previous episode, is if you have a concomitant injury that needs surgical management first, it's oftentimes that they'll go ahead and do something about the cartilage defect. If it's a grade 3 or grade 4, or they might even do a microfracture for one that's not so bad while they're working on that other injury. So perhaps they're reconstructing your ACL, and then while they're in there, it's easy enough to just do a microfracture or something, or a debridement, and just try to put the cartilage in a little bit better place. The types of surgeries, we did talk about this. So generally cleaning up the cartilage or cleaning up around the defect, you could have a debridement or a chondroplasty. You could have a microfracture for inducing a little bit of damage, and then some fibrocartilage will grow back. The OAT, which we talked about, the osteochondral cylinder transplantation. You could have the ACI or the MACI as well. So these are the most common surgeries I'm kind of seeing in the literature.
Mm-hmm. You guys got one more info about that, you just check out the last podcast. Kevin did a great job with that.
All right. So then getting into surgical outcomes. This paper was pretty good. It's from 2009, so it's a little older. So I do have some newer studies coming up, but I like this, and I like that Dr. Midhofer was in it. He's great. And then Holly Silvers, I think she was on our boss's sports physical therapy podcast maybe a year ago or so. So those were a good episode. But the title is Return to Sports Participation After Articular Cartilage Repair in the Knee, Scientific Evidence. So here they're going over what are the outcomes? Are these patients returning to sport for each surgery? And if so, at what level? So we'll get into that.
Let's do it.
Okay, so Midhofer et al. In their systematic review reported on 20 studies, and a pretty good N here, 1,363 patients after articular cartilage repair, with a mean standard deviation of 73% plus or minus 5% of patients returning to sports. So if you group all of them together, all the different surgeries, about 3/4 of them are getting back to sport. That's pretty good, I would say. Glass 3/4 full there. In patients after specific articular cartilage repair procedures. So we'll break it down a little bit by the type of surgery. So return to sport rates after microfracture was 66% plus or minus 6%. And we did talk about this in the previous episode. Microfracture is not the best for returning to higher level sport, but they didn't differentiate between the level of sport. So maybe this is just a recreational exercise type thing, but just something to keep in mind. But from this paper, at least, it was more encouraging than I thought from what some other studies were saying. Following the ACI, so because this was an older study from 2009, they didn't report on the MACI at all. So just keep that in mind. I think the MACI outcomes are a little better, and I do have a study coming up that will talk about that. But for the ACI, and again, these are usually larger injuries, so they are a little more complicated than what you'll see with a microfracture. But the return to sport rate was pretty similar. So 67% plus or minus 17%. So varying outcomes there, but they're pretty high. I think you could say almost as high as 3/4 in most cases. And then really good outcome here for the OAT. So this is looking at more of your medium to small size lesions that might extend into the subchondral bone. They had a 91% return to sport rate plus or minus 2%. So really good outcomes for the OAT for returning to sport. Well, how long does it take to return to sport? What could we tell our patients as a consideration? So the average time to return to sport, the range was 7 to 18 months, depending on the surgery. Microfracture was 8 plus or minus 1 month. So, 7 to 9 months. And I think I would think of that as that it's not usually done in isolation. So this is probably with another type of surgery, perhaps an ACL. And then we're seeing close to that 9-month range. So just keep that in mind. I think a microfracture by itself, you'd probably be back sooner than that, but they don't do that a ton in isolation. For the ACI, this is a long recovery, 18 months plus or minus 4 months. So, that's a pretty significant procedure. So it's that 2-step procedure. So I think that kind of makes sense there. The OAT was 7 months plus or minus 2 months. So I think more in line with the microfracture, maybe a little faster than like a traditional ACL or something like that, but still quite a bit of time for all of these. And then most importantly, I think here is what patients would want to know is, can they get back to their previous level of activity? And that's important. So the average return to sport at the pre-injury level for all three combined was 68% plus or minus 4%. The microfracture was at that exact number. So 68% were returning to a previous level. The ACI had 17% returning to the previous level, plus or minus 12%. And the OAT, although it had the highest return to sport rate compared to 91% return to sport, 70% were getting back to their previous level. So I think it's a pretty big injury, but all in all, I was pretty encouraged by these. I thought, you think of cartilage surgery as a pretty big deal. And with mostly 70% or so returning to sport, and then, of the ones that do, maybe 70% of them returning to previous level, it's not so bad, I think. So I thought that was pretty cool.
Yeah. Yeah. These are really cool pieces of data here and very encouraging too. Kind of my thought, and I don't really know if this is the case, but a little bit surprising with the ACI, right? So hopefully the MACI is a little bit better, which it sounds like it is. You're about to talk about long time to return, although that is 2 surgeries, but even still, that's a long time. I've even had surgeons tell, and I don't know if this is, maybe we don't have enough data, but I want to say Midhofer has patients wait 2 years. So that's one of the things to consider if you're like a youth athlete and you're trying to return back to sport. Man, 2 years, you just lost like your entire career for the most part, right? That's kind of crazy. I think the other thing, and you had mentioned this too, is that for an ACI, that's for a larger lesion. So maybe one of the reasons why these numbers are skewed is because it's just more damage to the knee. And if it didn't really control for concomitant pathology, if you have a lot of stuff going on in the knee, so if you have a bigger cartilage lesion, that's a sign maybe you had multi-ligaments, something else involved. So who knows? I mean, maybe it is more relevant just because if you're doing an OATS procedure, or excuse me, if you're doing ACI, there's a chance there's more damage. So just expect for it to take longer. But it could just take longer because there's concomitant stuff too if they didn't, control for that. But overall, good information. I'm kind of excited to see what the MACI brings to the table.
Okay, and I thought this was pretty cool here. So obviously, there's a lot of things to consider for outcomes. Like there's a range for a reason, and I think the amount of different factors that somebody has going on, like you said, the size of the lesion or the type of the lesion is going to affect their return to sport rate. So this is from that same study from 2009 with Dr. Midhofer. And this is looking at factors affecting return to sport after cartilage repair. So basically, they go through the gamut here, and they kind of look at how does age affect these recoveries for the microfracture, for the ACI, or they call it ACT here, or the OAT. So there's quite a bit of influence for these different things. So I think very generally, older patients don't tend to do as well. So all the plus signs there for each thing means that it's affecting the return to sport rate. So if you're older, you're probably not going to be doing as well at your return to sport rate. You're a 38-year-old athlete. It's probably harder for you to get back than if you are 18 years old. So keep that in mind. The duration of the symptoms matter. So if you have a longer time with symptoms, you've had symptoms for 6, 10, 12 plus months. For all 3 of these surgeries, it's probably a little harder to recover from and get back to your sport. For the lesion size, I think the ACI, because it deals with larger lesions, it's not impacted as much. But if you do an OAT, which is made for like a small to medium sized lesion on someone with a large lesion, it's going to impact the long term outcome. It's going to impact if you return to sport. So that's why getting the appropriate surgery for the appropriate lesion size matters. The lesion location, if it's in an area with a lot of weight bearing going through it, I think that's going to matter quite a bit. Um, your previous number of surgeries, and I'm surprised for whatever reason the OAT isn't involved with this one, but for the microfracture and the ACI, if you've had a lot of previous surgeries, it's going to have an impact on your return to sport. What skill is the athlete? It's going to have some type of impact. So I think this is a good table to look at, and you can go back and look at the study and kind of search for this second table too. But it is, I think, important things to consider from a clinician standpoint is you're asking if you can about these things, or you're looking at the operative report and trying to figure out what was the lesion size, what was the location of the lesion, and just figuring out which of these things are relevant to the patient in front of you, considering what surgery they had. So I thought that was pretty cool to include in the study.
Yeah. I think it's great. I think there's some really good clinical utility here. Sometimes, and this is where my brain goes, you have a post-op ACL reconstruction. I'm like, all right, 9 months is when we're going to get back. Right. But it's probably not reasonable. There's so many different factors that go into this. I think a lot about like rotator cuff repair is kind of the same deal. Like, how big was that tear? What's the tissue quality? How old is the patient? Do they have diabetes? They smoke? I bet you these factors are probably relevant for a lot of different surgeries, but definitely seems like it's relevant for these things. So you can base your return to sport on a lot of these different factors, which I think is going to be really important for the patient and also for the physical therapist, because we know how kind of fast to progress these folks. If a lot of these factors present, maybe go a little bit slower, right? And then just giving them some expectations, like, I think it's going to take longer or maybe shorter based on the size of the procedure you got. So really cool stuff. Love studies that do things like this.
Yeah, I think that's such a good point because you see so many patients, especially with ACL, it seems like, that are younger and want to get back to sport, and they're like, ACL takes 9 months. Why aren't I back yet? It's month 10. I see on TikTok everyone's back at month 7. And then you just gotta tell them that these broad guidelines are really helpful for clinicians and patients to understand, but every person's different and every knee is different, and we don't know, or we might have the benefit of knowing what else was going on in your knee at the time of the surgery. So I think those types of things help explain why there's such variance person to person. So it is interesting.
Yeah, for sure. And I think especially for the knee, I mean, you're starting to get into this world of multi-ligament plus cartilage plus other stuff going on, and it just gets complicated, unfortunately. And the more stuff that's occurring, it's probably going to take longer, right?
Mhm.
And if it's less, probably not so much, but just interesting. It's where that art comes into place, I think, as a physical therapist.
Hey friend, if you're liking this content, I have something I think that you're really going to love. And that would be a master course on rotator cuff related pain and rotator cuff tears. Having the patient come through the door and you don't know how to treat their pathology, that stinks. You feel like a fraud, you're just making stuff up, it's not good stuff. It's also pretty dang tough staying on top of all the literature that's coming out all the time. Well, guess what? I have done this for you by making a master course on rotator cuff related pain. Well, what kind of stuff do you go over in this course? I've got an evidence-based guide. We go over diagnosis and special tests, my favorite beginner, intermediate, and advanced exercises, how to modify your patient's training in the gym so they can keep on working towards their goals and not hurt themselves more, my favorite evidence-based manual therapy techniques for these folks, case studies on how to treat non-op and post-op patients, as well as the exact rotator cuff related pain protocol that I give to my patients when they come to see me with this common issue. Now that sounds pretty good, Dan, but how much does this cost? How does $1 sound? Whoa, $1? That sounds crazy. Why is it so cheap? It's mostly because I don't know how to run a business, but I do know about the rotator cuff, and I'll teach you all about that. This all comes with a subscription to Fitness Pain for Insiders. It's $1 for a 1-week trial and $25 per month afterwards. However, you can cancel at any time. If you don't like it within the first 7 days, just tell me. I will cancel and refund for you. Plus, I have a lot of other really good courses in there as well. We have master courses for cervical radiculopathy, lumbar radicular pain, lateral ankle sprains, and what I'm working on next is, you guessed it, your favorite, shoulder instability. So click on that link in the description. It's $1. Go ahead and get started, and I'll see you on the inside.
Okay, and then this was just another cool chart from that same study. So again, I thought it was a really good study, probably worth checking out, even though it's a little older. I think maybe some of these numbers might be a little bit updated since then, but the general stuff they included was really cool. So how does this stuff compare to return to sport rates of other major surgeries that we see? So If we look at return to rate percentages, like what's the return to sport percentage in the cartilage repairs versus other major injuries. So ACL reconstructions, the range, 53 to 81% return to sport, not necessarily prior level, but return to sport in general. So meniscal repairs, a range of like 56 to 85%, probably depends on the type of meniscal repair and the complexity. Articular cartilage repairs are right there, kind of with the other ones, 66 to 91%. Big range for microfractures, 44 to 100%. For the autologous chondrocyte transplantation, a 33 to 96%. And then for the OAT, really good here for the OAT, 86 to 94%. So some of these cartilage procedures are even a little bit better than your meniscal repairs, and maybe even a little bit better than your ACL reconstructions, but not too different, which is pretty cool, because I think going into this topic, I thought cartilage was probably a lot worse. But if our folks can get back from ACL and meniscus repairs, I think with the right surgical technique, they can get back with cartilage surgeries as well.
Yeah, man, just oats for everybody. Give them the oats.
Oats, they're good for your heart and they're good for your knee.
Yep.
It's such a great thing. So treatment considerations. These are two of the studies I think that I wanted to highlight for getting into how to think about treating these things. Look at that paper down there. Look at those authors, Mike Reinold, Lenny Macrina, our two bosses. Pretty good. So
yeah.
This paper was from 2006, so older, but I think the concepts are great. It's a current concepts paper that group of researchers did a lot of for a lot of different things that I think were helpful for PTs. So that was current concepts in the rehab following articular cartilage repair procedures in the knee. And then the other paper is from 2009, return to sports participation after articular cartilage repair in the knee, scientific evidence. That was the one with Dr. Midhofer. And then just a quote here that I thought was relevant. So a similar level of ambiguity is found within the post-op rehab after surgical intervention for the treatment of cartilage injuries. Specifically, there is a limited body of clinical investigation into the efficacy of different physical therapy protocols. Therefore, most rehab protocols are guided by anecdotal evidence that is surgeon specific. So we do see, I think, again, it's a little bit older. I do think we see a little bit better guidelines now, perhaps, but we don't have broad sweeping guidelines for how to treat these things. I think it comes down a lot to some recommendations by the surgeon based on the specific surgery. And then we can use some of these rehab principles that we'll talk about in conjunction with that to hopefully provide the best treatment that we can.
It's always sad when we don't have great research to guide us, And the other thing I will say is that I wish there's more of the current concepts. I don't know why, but Mike and Lenny did a lot of these, and it doesn't seem like other folks do, but very useful.
Yeah, totally. There's something about obviously looking at the research yourself, but it's also so nice to just have experienced clinicians, and they would always do those papers with surgeons and then just do them together. And, that's an expert guided paper, and you learn a lot from them. And even though, maybe not every single thing is something you would do or agree with, it guides your treatment in a in a very helpful way. So yeah, more of those would be cool. But just the principles of post-op rehab. So you have someone that came in with one of these surgeries. I won't get into each specific week and phase or anything like that because there's too much variance. But what are we considering? So obviously, you want to individualize our rehab programs. So consider the patient, their history, everything we talked about from that table from the Dr. Midhofer paper, I think is important. Like, how long did they have symptoms? Have they had any concomitant pathology? Was there any other previous surgery in the knee? All that matters. How big is their lesion? If we could figure that out, would be helpful. And then if they did have surgery, what were the specifics of the surgery? I think getting the op report could be pretty helpful. So patient health gives a lens into the cartilage health and the quality. So if you have someone who's just, largely unhealthy, they have a bunch of metabolic health issues, you might assume that the quality of the tissue isn't great. And that's something to consider. Obviously, the location of the lesion determines weight bearing. So it's not like we can necessarily say for a microfracture, for a MACI, for an OAT, you're non-weight bearing or you're partial weight bearing for this long. I think it depends on where in the knee the defect is. And I know in that current concepts paper, they talk about, well, if it's on the back of your patella, you might be able to weight bear locked in extension right away because there's not much force going through your patella there. But we might be a little more cautious on how much we flex the knee versus if it's in a weight bearing part of the joint, you might be non-weight bearing for a period of like 4 to 6 weeks. So it will depend on the location. That's why there's not one specific cartilage repair protocol. The second big principle here that we've talked about is you want to create a healing environment for the knee. You want to allow for healing and maturation of the surgical repair. Weight bearing and range of motion are key for cartilage healing to prevent proteoglycan loss. So if there is some type of weight bearing, a lot of times, from what I saw, surgeons will do, if they have to non-weight bear for a little, they will, or they'll let you go right ahead into partial weight bearing and passive range of motion to just kind of expedite that process of healing the cartilage. Just understanding the biomechanics of the knee is helpful. This can allow for more or less weight bearing based on where the repair is, and understanding that if you have maybe a repair somewhere in the posterior portion of the knee, you're a little more cautious with your flexion, passive range of motion. Your exercises might not be pushing into a bunch of deep knee flexion. The fourth big principle is that we're trying to reduce pain and swelling. We did talk about how swelling and active inflammation can have a deleterious effect on cartilage health. So we're just monitoring that over the course of time, like any post-op knee surgery, and trying to achieve that quiet knee as soon as possible. So yeah, I thought that was some good stuff there.
Yeah, I like it. Keep it going.
All right. So more of these principles, these were highlighted from kind of both papers, but we want to restore soft tissue balance. So if these patients are non or partial weight bearing for a period of time, we want to maybe be doing some soft tissue work on them, passive range of motion, just trying to get things feeling better. Restoring muscle function. Similarly to the ACL, we can see arthrogenic muscle inhibition. I think anytime you have that prolonged swelling and inflammation, you could have AMI with that, and that's just something you can easily assess, I would say, by looking at someone's voluntary quad contraction. And if they're, you see those quivering quads early post-op, they're not able to achieve full extension with a quad set. They probably have some AMI, and there's things we could do for that. We want to enhance proprioception and neuromuscular control. We don't want to neglect that. They're not moving their knee much. Swelling can inhibit that awareness of the joint. So that's something that we'll work on. We want to control the application of loads, monitor the joint line pain and effusion, obviously, but we want to gradually progress that. And then just having constant communication between the patient, the PT, and the surgeon. Make sure we're all on the same page of how we're progressing. If you're ever unsure, I think most surgeons are open to communication. And you just say, hey, what do you think about adding in the stationary bike at, this point? Or what do you think about starting some external loaded exercises at this point? And, if they don't give you a specific protocol, I think they're pretty good about giving their thoughts on that. And it's better to check with them than guess and progress a little too quickly, I think.
Yeah, good guidelines there. Yeah, it does, in my opinion, kind of look a lot like, let's say, an ACL reconstruction or something along those lines, with maybe a little bit more variation in the type of procedure and how big the lesion was or something along those lines. Mm-hmm. It almost reminds me of kind of like a meniscus repair, but it maybe takes a little bit longer to get back. And it seems like a lot of those precautions early on are really based on where that cartilage lesion is, which is very similar to the meniscus as well. And then maybe the type of repair is going to dictate the speed. It doesn't seem like maybe that's the same for the cartilage procedures, unless it's one of the ACIs or MACIs, which takes a long time to mature, I guess. Just seems to be very different than the OATs or the microfracture. But maybe that's the thing to keep in mind, is that those are just a different beast. The ACI, the MACI just take a long time to get better. But the OATs, the microfracture is kind of similar to the meniscus, maybe takes a little bit longer, something along those lines.
Okay. So more for rehab recommendations. So this table was just from one of those studies. biologic and rehabilitation phases after articular repair. And they're just matching the biologic phase with the rehab phase. So just so you can have some concept of maybe what's going on from a biological standpoint and then what we're doing from a rehab standpoint. So early on in phase one, the graft is trying to integrate into the knee. We're trying to let things heal. And for rehab, this is your protection and joint activation phase. So you're trying to let things calm down. I think less is probably more in this phase. We're trying to let things heal. As you said, this is so similar to how we treat any early post-op with the knee. But, any of those early post-op repairs or reconstructions. So a meniscal repair, a ACL reconstruction, these cartilage repairs, that's kind of phase one. Phase two, from a biologic standpoint, is the cartilage is undergoing a matrix production and organization, kind of laying down new healthy tissue in the extracellular matrix, and collagen's getting organized and the cartilage is getting healthier and healthier. And this correlates with the rehab phase of progressive loading and functional joint restoration. So we know progressive loading has good impact on cartilage health, and you're probably helping the cartilage lay down more collagen in response to mechanical loading. So that's kind of how we think about that. Phase three, from a biologic standpoint, is repair cartilage maturation and adaptation. So the cartilage is just continuing to mature and adapt into full healthy cartilage. And this is correlating with activity restoration. So, I think of the physical therapy process as, necessary really to expose the new cartilage to loads. And those loads are almost like fertilizer for the cartilage. I think it's helping the cartilage become healthier and healthier, which is kind of a cool way to think about it with the patient is you're doing like the necessary work to, we lay down the seeds of the cartilage during the surgery, but now we have to fertilize it. So if they're into trees and landscaping like Dan is recently, this metaphor will be perfect.
I was going to say, Kevin, are you becoming a lawn guy? Is that your thing now?
It is fun. I can't wait for spring. I think I'm going to try to get a garden going this year.
Yeah, it's a good thing. It's a lot of fun. Trees, lawns, and birds. That's my life nowadays. So that's it.
It's good stuff. Okay. And then this is just weight bearing guidelines and criteria for progression after articular cartilage repair. So I won't go through this whole thing, but it's very, very similar to most post-op protocols, but I thought it was helpful to look at. So, if you do have like an OATs type procedure, you might be touchdown weight bearing for 2 weeks and then progress to full weight bearing by weeks 4 to 6. I think it's going to, again, it depends on the location. This is specifically for a femoral defect. So I thought that was pretty good to see. And maybe each specific surgeon will have different criteria or recommendations for this. But for your more reparative techniques like a microfracture or ACI or even the MACI, you might be touchdown weight bearing for 2 weeks and then progress by 25% body weight per week. And oftentimes these people are kind of in this process for the first 6 to 8 weeks. I think it depends on the surgeon, but it can be kind of conservative, specifically for the ACI and the MACI. For patellar and trochlear defects, like I said a little earlier, because you're not necessarily putting a lot of weight through the knee, through this structure, the patellofemoral joint in weight bearing alone, it's more with deeper ranges of knee flexion. You're probably okay immediately weight bearing with the brace locked into 0 to 10 degrees of knee flexion. So that might be why you see some variance on weight bearing protocols. And then just normal progression stuff from phase 1 to 2, kind of arbitrary phases here, but you're trying to just get back full motion, reduce pain, achieve that quiet knee with minimal or no knee effusion, reduce that AMI, get back good quad activation, normal gait cycle stuff, and then progressing to more higher level physical therapy that we think about. So return to sport type stuff. And this is where we might bring in our isokinetic or iso metric testing would be very important to do. And as we get even further back to sport, some hop testing, if you got force plates and stuff like that, I think the rehab starts to look very similar. So I think special consideration for weight bearing and check with your surgeon on that based on the location and the procedure. That's going to vary. But then looking at this chart, the phase 1 to 2 and 2 to 3 is very similar to other knee surgeries that we see. So those same principles that you use for all your knee post-ops, I think still apply here, and you can rely on for good outcomes. Okay. And then just kind of summary here. Communication with the surgeon is key to understand patient and surgical specifics. That goes without saying. I think you because there isn't one type of surgery here, and there are so many different locations in the knee this could be, communicate with the surgeon and figure that out. For most procedures, a period of partial weight bearing is likely, so just be aware of that. For initial stages of rehab, our general post-op principles are at play. So kind of what I was just saying. I think this is the most important thing in this whole entire show. The long-term goal is to achieve fitness pain-free. And the way you do that is you like and subscribe to our show here. So that's the only chance you have at a good long-term outcome. And I think you really got to consider that.
Yeah, most viewers miss that step. They do not like hitting that like button. They're like allergic to it. But they should hit that like button. You know what I mean? That would help. All right, so now you're an expert rehabbing cartilage injuries, but cartilage injuries often coexist with ACL injuries. We have a really good video for you. I'll leave a link in the corner right by Kevin's head. We go over a 12-step process for rehabbing folks after ACL reconstruction. Click on that video, and I'll see you there. If you're watching this on YouTube, please, please, please hit that like button. Consider subscribing to the channel if you enjoy this. If you're listening to the podcast version of this, please give me a 5 out of 5 rating. It helps tremendously. And lastly, if you want to go that next step and support me further, consider subscribing to Fitness Pain-Free Insiders. So Insiders is like Netflix for physical therapists and coaches working with painful folks in the gym. You've got access to 100 plus webinars, ebooks, and courses. More recently, I've been taking all of my best content from YouTube. I've been taking out all the ads. I've been organizing it in a really step-by-step fashion in an entire course so you can easily go through it. And I add additional pieces to this to enhance your learning, right? So I just finished up my lateral ankle sprain course. And one of the big things I add to this was a protocol. So essentially, what do you do week 1, week 2, week 3, week 4, week 5, 6, 7, 8? You know me, I like working with athletes. I like working with really fit and strong people. So it's going to be a lot more robust than your typical protocol. Also, you have access to me. So inside of Insiders, you can leave a comment and I'll get right back to you. I also have physical therapy CEUs inside of Insiders. So if you take the course, Essential Coaches Series, get a bunch of CEUs. And what's even better is you can start for just $1. After that, it's $25 per month. It's going to be the cheapest CEUs you can get. It's by far the highest value program that I offer at the cheapest price. So head over to fitnesspainfree.com, click on the program's link, and then click on Fitness Pain Free Insiders to get started. I'll also leave a link in the show notes where you can check it out.